Good morning and welcome to the fourth Respiratory Futures webinar. I'm very, very pleased to welcome Dr. Julian Flowers, Head of Data Science from Public Health England, and Dr. Simon Simon, who's Managing Director of Methods Analytics. And the topic today is respiratory data science. Over to you both.
Okay.
Good morning.
Good morning. Should we do the first slide?
Yes.
So I'm just going to kick off a little bit about data science. So it's in my title. I suppose it's old wine in new bottles, really, because a lot of us have been analysing data for a long time, and data science is, I suppose, a recognition that data is increasingly important in the modern world, and we need to make best use of it. So quick rundown of what it is. It's about the way we use data. So it's analysis and visualization is a real thing. People talk a lot about big data. In healthcare, big data is a really big thing. It's not just the data that we produce from health services, it's data that we collect in all kinds of ways about health. I think linkage is the next frontier for this. And then there are other data sets that we have, like, for example, NHS Choices generates huge amounts of traffic about what people do and think about various things. And there are kind of 4 V's in big data. There's volume, variation, and velocity and veracity. So velocity is about being real time, and veracity is about the fact that most of the data we collect is of dubious quality. And how do you live with that? So that's kind of a quick rundown of what data science is. If you move on to the next slide. And as we know, I mean, my experience in respiratory disease, there's actually a huge amount of information out there, and I've spent some of my past few years just trying to gather as much as I can into one place, and we'll talk a little bit about that. We still know that there are massive service variations. And at the end, we want to just do a little bit of futurization about what this idea of data science might bring. Okay. So what's available now? So I think, just to put things in context, this is a visualization that I created for Public Health England. It's taking something that ONS produced, which is a data set of all the deaths this century in England. And respiratory disease is the 3rd biggest killer. And I don't know whether you can see this, but basically the number of deaths from respiratory disease hasn't really gone down over the last 13 or so years, as opposed to cardiovascular disease, and cancer is about the same. So it still remains an important cause of death. And this tool, you can go on the web and have a look at it. It allows you to drill down, so you can put in a search term and find a particular cause of death within respiratory disease, or any other disease for that matter, and you can look at it by age. So I think we did this to illustrate that basically some increasingly powerful tools to allow us to take quite large data sets and make them much more accessible, so that in this one page are effectively 6 million deaths you can analyse. And the other thing that I've spent quite a bit of time doing is looking at respiratory disease at practice level, and we built a tool to do that. Practice profiling tool, and this is just one output of it, basically showing that you can get some insight by comparing different indicators, even if the quality of them isn't that great. So this shows that basically practices who are better at assessing COPD are also better at assessing asthma, and that's probably quite an important thing to know. And finally, before Public Health England and in Public Health England, built this tool called Inhale, which is it's an interactive atlas of health conditions, health and lung conditions in England, which allows sort of CCG and local authority level exploration of all kinds of data sets that we've assembled into one place, and you can visualize it lots of different ways. And it's reasonably well used across the country. So there's a lot we can already do, there's a lot of data out there. Part of the trick is to try and manage it into sort of manageable chunks. There's a lot of information overload, if you like.
The other thing is that Julian and I spend a lot of time building data tools that have graphs and maps and all sorts of things like that. But the trick to getting it used is actually often not to present graphs and maps, but to sit and stare at it and write a paragraph.
That's true.
Put narrative on it, because most people are not able to intuit information easily from graphs. So actually write a sentence in English.
Yes.
But that takes time.
Can I leap in there? I'm sure there's a lot of people thinking, what does that mean when you say write a sentence in English? Can you unpack that a bit? What's a meaningful sentence if you're a GP working against the clock with quite a high incidence of COPD in your practice?
Well, it would be what Julian did when he looked at this graph, practice profiling, which is just looking at that, you can see, well, there are an awful lot of grey dots and a few black dots. But what Julian said was, we can see that there appears to be a correlation between the ability of practices to assess asthma patients and the ability for them to assess misspelt COPD patients.
Oops. But basically, this chart kind of suggests that there's a relationship between the two variables, and you can measure that.
And you could put maths around that and look at correlation. But Julian can see that in the graph, but writing that narrative which explains what he sees is the bit that adds value.
And that's often the bit that's missing, isn't it?
That's because it takes time.
It is.
Absolutely.
And if you take something like this, there are, I don't know, 20, 30 indicators in there. And if you cross-tab them all, that's 900 paragraphs you might need to write. So you can't really do that. So actually, there is a sort of human process of synthesizing that down into sort of key messages. What does all this really say? And it's just true, we don't do enough of that. And a lot of these things we do sort of for ourselves so we can explain to other people.
Yeah.
And part of what we perhaps is stirring up in a good way today is helping people to better articulate what they need from data. So don't let me stop you, but I think it's a really important point.
I should also say that, I mean, my experience mostly is what's already publicly available and repackaging it. And we know that that's often, when you do that, you realise that it often doesn't measure what people really want to know, or it doesn't tell you things that you think it should.
And would you say, and I'm sure we'll be going on to this, that for a lot of many healthcare professionals, you don't always know what you need to know. That there's a kind of self-defeating issue here, isn't there? In terms of it's quite complicated where there are a lot of indicators. So for some healthcare professionals, it's where do we start and what do we need to know to ask the right questions? So actually,
well, it's a two-way problem in that people who play with data don't always know what it is that clinicians would like to ask of the data, and the clinicians don't know what to ask because they don't know what data there is available to answer questions. So the way to deal with this is to sit down together in a room with the data guys and the clinical guys and have a fairly wide-ranging open conversation about, well, what would you like? What's the ambition? Well, we can't do that, but we can do this, which is quite close. And we've also got this bit of data which could answer that. Is that interesting? And you spend quite a long time workshopping this in order to come up with something that might be useful. And then you go away and do it, and sometimes it's useful and sometimes it's not.
And what that suggests to me is that it isn't necessarily that easy to make a one-size-fits-all tool.
No,
everybody working in respiratory healthcare in England and in the UK.
So Simon and I tend to deal with populations. So I deal with, Simon tends to deal with service populations. I deal with kind of administrative populations, if you like. And the trick is, how do you make the link between what you see at a sort of aggregate level and how does that relate to when you're managing an individual patient? Yes. And that's not an easy thing to do. And it's a bit like evidence-based medicine. The trick is that people do research which is supposed can be generalised, so it applies to people and everybody of that particular ilk, if you like. But as a clinical practitioner, you've got to particularise it to that patient. Does it apply? And there's always lots of exceptions. So there's quite a skill in applying information like this. But for this sort of example,
And we'll probably be picking up on the other end of the story, personalisation, somewhere later in your presentation. So please carry on.
Moving back to where we were.
Oh, this is just another sort of. So I think one of the things that I'm particularly interested in is there's a whole science of visualization, and there's some gurus like Tufte talk about small multiples and multivariate analysis. So presenting lots of information in a small space is an important thing to do. So this particular chart is the trends in COPD admissions in where I come from, and you can see West Norfolk going up, Great Yarmouth going up. In fact, everywhere going up slightly, but West Norfolk in particular. So if you're the commissioner there, you might be asking questions about what's going on relative to everyone else. So this is a kind of quick and easy way of just raising a question.
Yeah, and that's true of nearly everything that we say with this kind of data, in that data like this very rarely actually answers a question. What it does is it helps you focus your question and ask more and more granular and more definitive questions. So this slide of Julian's shows that West Norfolk and Great Yarmouth and Waveney appear to have a higher and increasing rate of emergency COPD admissions than other localities nearby. Well, that's all very well, but it doesn't tell us very much. What it tells us is commissioners, clinicians locally need to go into those geographies and say, well, why is this going up? Why is it higher than it has been? What has changed? So the data won't tell us that, but it tells us what to go and find out. And this is a graph of mine. It's simply another example of kind of information that's easily available now. So this is a funnel plot from autumn last year, looking at every CCG in the country and an age sex adjusted rate of emergency admissions for COPD. And as you can see, there's a huge scatter across the country. In deference to Julian, the organisation focusing this plot, the big green blob, is Cambridge and Peterborough CCG. And as you can see, they are nicely just below the national average. But there are organisations here with admission rates ranging from 6 or so per 100,000 resident population up to well over 40. And that's a huge level of population level variation. And obviously there's something driving that, and understanding that could be hugely beneficial. This is another screenshot, and this is looking more from the provider view. So because of where we are here at BTS, I've picked on UCLH, and on the funnel plot you can see that their emergency readmissions within 30 days of an emergency admission, they're the big green blob just on the lower left of the funnel plot, and you can see that they're just above average for their population. It's the same time point. And looking at the trend line, they've bobbled around or within the national cohort between the upper red and lower green national control limits for the last 3 years. So you can see again, there are some organisations of a similar size, so x-axis, about 50 to UCLH, who have very, very low rates of readmissions, less than 10%, and there are some up there at well over 40. Again, huge variation in what happens to patients after they've had a hospital episode. This is another metric from UCLH, and I've just looked at Crude in-hospital mortality rate. Now, I'm a fan of Crude mortality. It's not useful for benchmarking because there are factors due to population and service, which mean Crude rates can't really be compared. But within a hospital, I would suggest that Crude rate is a hugely sensitive measure over time. And if you look at the trend line at the bottom, if I was a UCLH respiratory physician, I'd be pretty pleased with myself. because that's gone from above the national average, but not an outlier, to well below the national average and stayed there for a long period of time. And looking at the range of organisations nationally on the funnel plot, it's 8-fold variation in crude mortality. Now, as I say, you can't really use crude mortality as a comparator because populations and service structures are very variable. So getting on to, in the final few minutes, some thoughts about the future. All of us now, or the vast majority of us, now carry around very powerful personal computers in the shape of telephones, and there's an enormous amount that could be done with that. Remote sensing, wearable technology, is becoming increasingly prevalent. I'm currently looking at buying a watch that will track heart rate and movement and all sorts of things for some sports I play. But that information actually says an awful lot about my health. And there are already people building predictive algorithms that work with that kind of information and surface it through alerts on your phone that can be used to inform people of risk of adverse health events, so people can then modify their behaviour.
So I was at a conference last year actually, and there's a lot going on in Silicon Valley, as you might imagine, and in California, where they're really using this sort of thing to keep people out of hospital.
Yeah. Because
they're monitoring their health states in real time, and they've got predictive algorithms for people who are quite sick, like with, you know, to sort of get ahead of decompensation in people with COPD and so on, and intervene early to try and keep people out of hospital. And apparently it works, and they obviously have huge financial incentives to do it. But the technology is improving all the time. And this kind of big data thing, where the data is fed to data centers, analysed, and so on, then alerts a physician or a nurse or the patient to take some action, is where things are heading.
Well, it's real already. I know that in congestive cardiac failure, people now have internet-connected scales, and when they get up in the morning, the scale's by the side of the bed. You step on it, it weighs you, and if you're starting to retain water, an alarm goes off.
Yeah, I have one, but not for my heart failure.
Just out of interest then, your alarm goes off, what happens next? At some point you'll still need the intervention of a healthcare professional.
Not necessarily. I mean, in somebody with, you know, chronic congestive cardiac failure, if they're starting to retain water and weight starts going up, it may be they already have a plan in place with their physician which says when you've gone from 70 to 75 kilos, increase your dose of diuretic by X until it comes back down again.
And the same thing correlates for someone with asthma or COPD.
Yeah. So it may be take antibiotics or increase the steroids or take your inhalers more frequently, or maybe phone your doctor. But there's something about prediction, so planning ahead. So and those readmissions that Simon was showing for COPD, they're all exacerbations or not very well controlled COPD. Some of that could be planned ahead for.
So it's a better use of as we all know, reducing resources we have now to basically cut to the chase, so that when the patient finally if they need to see a clinician, it's because it's got to a point where they really do need to see that clinician.
It's enhancing self-management.
Yeah. I mean, thank you very much. We've had quite a few questions come through, and I know we've had some questions come through ahead of today's debate. Because time is a little tighter with this webinar, we are going to post the questions and answers from Julian and Simon on the Respiratory Futures site later today. But before we sign off, could I just ask you one question that came through ahead of today's debate? It's from Anne Rodman, who asks, how would you suggest overcoming the poor data input in primary care with over-reliance on QOF templates but inconsistent adherence to guideline recommendations, such as recording asthma and COPD exacerbations using read codes?
Shall I?
Do you want to start?
Okay, so basically it's not an easy thing to do, but there are 4 basic ways of improving data quality. So the first one is get the data out there, get it used with feedback loops, because if we don't use it, there's no incentive for anyone to improve the quality. The second is, and the reason why people use QOF templates, is that there are incentives to do certain things, like QOF, and we have to accept that. But if we make it easier for people to record exacerbations by being a bit more consistent, and you have to get the colleges involved and so on, that would help. The third thing is sort of having champions, making this more of an issue, and there are people who sort of try and do that. And I think the fourth thing is data linkage. So if somebody is admitted to hospital with an exacerbation and that isn't linked back to their hospital record, to their GP record, then you lose that connection. So you can enhance the data in general practice by enriching it with data from elsewhere. And there are care.data is intended to try and do that. It's some way down the road, but that's kind of the way things are going. There are probably other things like, increasingly as we get to a patient health record, they have much more of a vested interest in ensuring that their information is, A, they understand it, and B, it's accurate.
Yeah, and comprehensive.
Yeah, but I think these things do take time, and we have incentivized certain ways of doing things through things like QOF. I think that we have to make good use of it, and we can do this kind of associative and correlational research to try and see where the biggest problems are, in terms of data quality.
Simon, do you want to add?
Julian's given a very comprehensive answer. The one thing that he's mentioned that I would pick out is transparency. If people don't see a point in entering accurate and comprehensive information because it is not used, they won't. So get the data out there, get people using it, get people looking at it, and where we do this, we see that data quality improves very rapidly because there's a reason to do so.
Yeah, absolutely.
That makes perfect sense. Thank you. Thanks for this whistle-stop, but very, very useful and I think interesting journey through data. As I say, I'd like to encourage people to raise more questions and continue the discussion on respiratory futures later today. Thank you very much. We'll now wrap up the webinar.
Thank you.